Good evening, everyone. Thank you for joining us this evening for our webinar on imaging of neuroendocrine tumors with Dr. Denise Chan. Before I introduce Dr. Chan, I wanted to call your attention to the chat or question function on the right-hand side of your screen. This is where you can put any questions that you would like us to ask Dr. Chan once she's done her presentation. You can put your questions in as she goes through her presentation, but we will address them at the end. So on that note, it's my pleasure to introduce you to Dr. Denise Chan. She is a dual-trained radiologist and nuclear medicine physician who did her residency training in London, Ontario at the University of Western Ontario. She has been practicing in Calgary, Alberta in EFW Radiology and Foothills Medical Center since 2008. Dr. Chan is the co-lead of nuclear medicine at the South Health Campus. She's a clinical assistant professor at the University of Calgary. Her research projects include starting Gallium-68 DOTA-TATE PET CT and prostate PSMA PET CT programs in Calgary. Dr. Chan, thank you so much for being with us this evening.
Great. Thank you very much, Jackie. And thank you for giving me the opportunity to present here tonight. So if you can see my slides, we'll be talking about neuroendocrine tumor imaging, about 30 minutes presentation, and then I'll be happy to answer any questions at the end. Just in terms of disclosures, I have no disclosures. So the purpose of this discussion is to talk about the different imaging tests in radiology and nuclear medicine, and to talk about their roles in the management of neuroendocrine tumors. As you already know, neuroendocrine tumors are considered rare tumors, and they comprise less than 1% of all malignancies. And they're a heterogeneous group of tumors with a wide variety of clinical presentations, the most common being the gastroenteropancreatic neuroendocrine tumors that occur in your pancreas, stomach, or bowel. But it also includes the pheochromocytomas, the lung, certain types of lung cancers, and other syndromes such as the multiple endocrine neoplasias. So why do we care? Well, the incidence is actually increasing, and part of this is because of better imaging tests and a greater awareness of this tumor. So in terms of neuroendocrine tissue are seen everywhere in the body, and the tumors can arise in different places. Now, neuroendocrine tissue have peptide hormone producing ability, and these tumors also have the peptide hormone producing ability. In fact, these neuroendocrine tumors, overexpress somatostatin receptors, and that makes it key in our imaging for the nuclear medicine component of the evaluation. They can occur in pretty much almost anywhere, but the most common is going to be in the digestive tract, and that includes the bowel, the small bowel, the stomach, as well as the pancreas. And we can also have tumors involving the lung as well. And we can also divide them into functional versus non-functional tumors. This is just an example, so you can see the locations of the tumors, the majority being in the digestive system, but some tumors also in the thorax. In terms of the diagnostic tools, we can break it down into the biological assessment, in which we look at the tumor biopsy and stain for certain markers, the most common being Ki-67. Then we can also break it down into what's called anatomic imaging, or what I call radiology, and that's the ultrasound, CT, and MRI imaging. And then there's the molecular imaging, which is nuclear medicine, and that includes Octreotide scans, MIBG scans, and the different PET scans. All of these different tools are used together and are complementary, not meant to replace one for the other. And there are biochemical markers, which I won't go into, but this includes the chromogranin A, the 5-HIAA tests. And again, these tests are important because it gives the clinician an idea of the tumor burden. So let's now focus on the imaging diagnostic workup. So the reason we're going to do the imaging is to identify the neuroendocrine tumor, where it's primarily located, and where it has metastasized or spread to, both locally and distant. And why is this important? Well, because it guides management. The first thing that the clinician would want to do is obviously remove the tumor if they can surgically. If they can completely remove the tumor, then maybe they can achieve cure. And then just follow up the patient. However, if you're not able to completely resect the tumor and the known metastasis, then it guides management in terms of where is the disease left. So if it's just localized to the liver, there are several types of management options we can use. We can cut off the blood supply to the tumors or do embolization. We can resect that part of the liver. We can actually do other techniques such as burning it or freezing the tumor, and then other combinations. If there's residual disease outside of the liver or including the liver, we can do other therapies such as somatostatin analogs. We can do PRT such as the lutetium therapy, as well as cytotoxic medications or chemotherapy. So knowing where the tumor is in the body is quite important for management. And again, we break it down into radiology and nuclear medicine. So let's first start with the radiology aspect. The first is ultrasound. Ultrasound is quite common, and you're probably all exposed to some sort of ultrasound test, particularly if you have an obstetrical ultrasound for when we're evaluating for the babies. Ultrasound is widely accessible in not just the hospitals, but also in clinics and in large and small centers. The good thing is that there's no ionizing radiation, and it's a reasonable price test for the health system. Sometimes we will pick up disease on ultrasound incidentally, and it will basically trigger further tests to find out what's going on. Basically, the idea is that you have ultrasound waves that are sent from the transducer to the tissue, and how it's reflected back tells us the composition of that tissue. The big thing that ultrasound is good at is trying to differentiate whether it's a benign cyst, meaning we're not worried about, say, this lesion in the liver, or if it's solid, which case then we have to decide, is this benign, meaning we're not worried about it, or if it's malignant, meaning this could be tumor that could spread or metastasize. So, for example, this is a patient who had an incidental liver mass, and you can see this large 5-centimeter lesion in the liver, and it's black, or what we call hypoechoic, and it's solid mass. So we know it's not a cyst, so now we have to further evaluate what this could be. Now, usually that involves going to another imaging modality such as CT or MRI to characterize that liver lesion. But there are certain types of ultrasound machines called contrast ultrasound that we can do, and we do that here in Calgary at Foothills Medical Center, and it's also offered in other academic centers such as Toronto. And this is contrast ultrasound, in which we inject little bubbles and see how the liver lesion, what the characteristic enhancement is. So this is an example of contrast ultrasound. You can see the bubbles filling up the lesion, and the pattern is basically telling us that this could be metastasis. Okay. The biggest thing with ultrasound that is really helpful, that's very helpful for neuroendocrine tumor, is basically guiding biopsies. And the reason being is that we want to put a needle into that liver lesion, and you want to make sure that the path of that needle is going through nothing important. So we do ultrasound guided biopsies, and this is routinely done, and it helps us to basically differentiate ultimately what is that liver lesion. Now, there are other uses for ultrasound. You can do endoscopic ultrasound, in which the surgeon or clinician puts in a probe and actually can sample and biopsy the pancreas or duodenal lesions, as well as we can do ultrasounds in the operating room to guide resections. Okay, so that's ultrasounds. The big study that would be ordered for neuroendocrine tumor imaging would be CAT scans or CT scans. Now, this is widely available. It's in large centers and small centers now. It does use ionizing radiation, but it's really the bread and butter evaluation for neuroendocrine tumor imaging. And the reason being is that sometimes patients will present with abdominal pain or bowel obstruction, and a CT scan is ordered and it picks up the tumor, as well as helps to stage it. And we often give IV contrast for the CAT scan or the CT scan. So in terms of the CT scan, it offers valuable information. It tells you where the tumor is and what that tumor is doing to the nearby structures. For example, here's a pancreatic mass, and we can see that it's starting to go into the adjacent blood vessels. Now, that's important information for the surgeon to know if how much they can resect or if they can resect it at all. It also tells us whether or not the tumor is spreading to the nearby mesentery or omentum and what it's doing to the other structures. So this is the adrenal gland. That adrenal gland is quite close and probably involved by the tumor. This is your kidney, spleen, and liver, and gallbladder. And here's some bowel nearby. So you can see where that tumor is and how it's what it's doing to the other structures. You can also look for distant metastasis. It's excellent looking for liver metastasis, lymph node metastasis, as well as very useful for the lungs. So the CT scan can give you a three-dimensional look at the part of the body, usually the abdomen and pelvis. Here's an example, a coronal image of the abdomen pelvis, just some normal structures. Here's your liver, stomach, part of the pancreas, and these are your small and large bowel. And we can see an enhancing tumor right here. And this is another cut through the same patient, and you can see the tumor here involving the small bowel. So the CT scan will also tell you what it's doing to the bowel. Is there a bowel obstruction? Is this mass causing bowel obstruction? Is it involving the vessels and causing the pain or ischemia to the bowel? So it's very helpful information. We do need to give IV contrast for the CT scan, especially for neuroendocrine tumors. And neuroendocrine tumors have a unique contrast enhancement pattern. It's seen in the arterial phase best, and you can see, for example, here's the liver, and here's a tiny enhancing liver lesion, and that's metastasis, and here's another one. So what we do is we scan the patient, we first inject the IV contrast and scan the patient in 40 seconds, and then we scan them again a little later, probably another 40 seconds later, and this is called the portal venous phase. So a little later as the contrast goes through the blood system, and you can barely see that liver lesion anymore. So it's important to give IV contrast and to get the right timing of that contrast, or you can miss small lesions. The CT scan is good at looking pretty much everything: bowel, stomach, liver, and pancreas, and it's excellent looking at the pancreas. Again, the pancreatic lesion is usually brightly enhancing on the arterial phase. And we can see what it's doing to the surrounding ducts, if there's duct obstruction or whatnot. Just two examples of a pancreatic lesion right here and liver metastasis. Now this was again taken in the arterial phase, and you can see the liver lesions quite well and the pancreatic lesion quite well. This is taken in the portal venous phase, which is later. You can see how the tumor isn't really showing up as well. This is a different patient, by the way. And here's the pancreatic tumor. It's not enhancing as well, but we can still see the tumor. And we can see that the tumor is actually starting to go into the adjacent splenic vein. So very important information that your clinician needs to know about these tumors, and it helps to guide therapy. Again, we are also very good at looking at the bowel. We can look for wall thickening, bowel obstruction, and what it's doing to the adjacent bowel. And sometimes we can even pick up very small lesions. CT scan has excellent spatial resolution where we can look at things as small as 4 to 5 millimeters. For example, this tiny little enhancing polyp nodule that turned out to be a neuroendocrine tumor. And this wall thickening in the bowel, again, this is another appearance of neuroendocrine tumor in the bowel wall. And of course, lymph nodes. So the tumors spread to the nearby lymph nodes and can sometimes cause, can involve the vessels and cause ischemia to the bowel. So this is important to pick up, as well as to know where the metastatic burden is. Now the lymph nodes on CT is described as being abnormal when it's greater than 1 centimeter, or if we can see this calcification or this twisting or fibrotic change to the adjacent mesentery. But because we use CT 1 centimeter as a criteria, we may miss small lymph nodes that are actually involved. And that would be important in when I talk about PET imaging and why they're all complementary. So as you know, neuroendocrine tumors can involve the lungs, and this is where a CT scan is really exceptional, and nothing can really replace the CT scan evaluation of the lungs. Here we have a carcinoid involving the airway. This is the left main stem bronchus, the airway, and you can see that tumor is actually blocking the airway, and this is causing collapse of the left lung, left lower lobe. And here's another example of the tumor in the airway causing collapse because of obstruction. So let's switch gears now and talk about MRI, or magnetic resonance imaging. It's superior to CT in evaluating certain solid organs such as the pancreas and liver. It has excellent spatial resolution down to 2 millimeters, and it's able to characterize the tissue. So you can confidently say whether it's a cyst or benign lesion much better than with just CT alone. We do give contrast, which is gadolinium, but it's considered to have a safer profile compared to CT contrast. And just so you know, MRI scans are a little bit more expensive, and it's not as available as CT scan, but it's in most hospital settings. In terms of liver metastasis, it's excellent, and it's considered the gold standard for evaluating liver lesions. We can detect lesions as small as 2 millimeters on some of our sequences. And so really liver metastasis, it's great. It's also excellent at looking at the pancreas and the surrounding structures. So here's an example of a pancreatic mass, a large one, and it's showing some enhancement with the gadolinium. It can also look at the stomach and bowel, but MRI is not so great with air, but it still can be useful. This is an example of a gastric neuroendocrine tumor in the stomach, and you can see it does still enhance, and we can accurately characterize where that is. And of course, lymph nodes, it can pick up lymph nodes. So here's that mesenteric lymph node. So this is just a summary, basically showing you that CT and MRI have excellent spatial resolution, and they give you 3D evaluation of the abdomen, pelvis, or whatever body part you're looking at. CT is excellent for the chest. CT is more widely available, but there is a radiation dose to it. MRI is available in most centers, but sometimes there's a bit of a wait list to get an MRI. And of course, ultrasound's widely available. It's good for differentiating a cyst versus solid mass, and it's helpful for guiding biopsy. So this is the radiology aspect. But let's switch gears now and talk about nuclear medicine. Specifically, let's start with the somatostatin imaging, which is Octreotide, and then we would go into the PET imaging. So as you know, somatostatin is the small peptide hormone that's produced in the hypothalamus and pancreas. And a lot of tissues in your body have somatostatin receptors. However, they have found that neuroendocrine tumors have more somatostatin receptors. And so that's where our Octreotide imaging is trying to basically take advantage of those somatostatin receptors. So they've created an Octreotide, which is an 8 amino acid somatostatin analog, so very similar to the normal somatostatin that we see in our bodies. And it's able to bind to the somatostatin receptors that are seen in a lot of tumors. So this is Octreotide. Just so you know, a lot of things, not just neuroendocrine tumors, can have somatostatin receptor expression. Other cancers, such as breast cancer, thyroid cancer, and other inflammatory infectious conditions such as pneumonia or tuberculosis or sarcoid can also have somatostatin receptor expression. So again, you can't just rely on somatostatin receptor as being it's a neuroendocrine tumor. You have to take into account what it looks like on other imaging modalities. So what is the indications for these somatostatin studies? Number one is to detect and localize the tumor and metastasis. Sometimes, although it's excellent CT and MRI, it's still not, it still can't always solve all the problems. And that's when Octreotide scans or DOTA-TATE scans can help the clinician be more confident that that is a neuroendocrine tumor or metastasis. It's also excellent for staging and to follow progression or recurrent disease. The other thing that Octreotide imaging is important, or DOTA-TATE imaging, is to predict response to the peptide receptor radionuclide therapy or the lutetium therapy. So basically, as you know, lutetium is bound to the DOTA-TATE, and they use that to treat disease. And so the DOTA-TATE or the Octreotide scan is basically a map of where the therapy will go. So let's just start with the Octreotide study. It's been around for 20 years plus, and it's seen in most nuclear medicine sites or centers. What we did is we took that Octreotide and we linked it to indium-111, and we use it on a gamma camera. Okay, so the same camera that you would do a bone scan, or if you ever had a lung perfusion scan, you would do the same gamma camera. Okay, it has a half-life of 2.81 days. There is a radioactive dose to it, to the patient, and we inject it, and we have to do 4 hours and 24-hour imaging. Now, some centers just do 24-hour imaging, but basically the patient has to make at least 2 trips to the hospital, injection and then imaging at least at 24. Some people even do 48-hour imaging. So it's not that convenient to the patient. When we do the pictures, we start off with a whole body, which is basically anterior and posterior pictures. Okay, and we do both. So here's an example of a whole body. We can see focal uptake here, and it actually corresponds to the tumor that we see on the CT. And then we can look at the whole body and look if there's anything else that we're worried about. Here's an example of another patient where there's uptake here in the upper abdomen and right here, maybe in the liver. And we can actually do SPECT CT, which is 3D, three-dimensional look at where that uptake is. And we can fuse it with a CT scan performed on the same day. We don't give IV contrast, but the CT helps us to localize where that is. And I can see that this is a mesenteric lymph node. Now, SPECT CT is very useful. Here's an example of that pancreatic mass that we saw on CT. They wanted to do an Octreotide study. We do an Octreotide study. Maybe this is the lesion here on the planar images, but I want to be sure. So I'm going to do SPECT CT imaging. And I do SPECT CT imaging, and here's the pancreatic mass, and that does not take up Octreotide. So that's very important. What was taking up the Octreotide was actually bowel. So nowadays, pretty much everyone does SPECT CT imaging just because it improves your accuracy for the disease, for detecting disease. Here's another example, small little, maybe 1 centimeter lesion in the pancreatic tail. See that enhancement on the CT? They want to know, is this pancreatic neuroendocrine tumor? We do the whole body. Doesn't look like anything on the whole body images. When we do SPECT CT, we can see clearly that there is focal uptake. It was probably just obscured by the other structures like the kidneys, for example, and the bowel. So we can confidently say, yes, that is a neuroendocrine tumor. And this brings us back to that MRI where there's that stomach, that gastric mass. This was actually missed on the MRI, and they couldn't find where the primary tumor was. And we did Octreotide study, and it clearly lights up easily in the stomach. So then looking back, they looked back at the MRI images and realized that, yeah, that was actually the tumor. It just had been missed. So again, that's sometimes how helpful the Octreotide study is. Now, just briefly, I'm going to just mention MIBG studies because some of you might have the MIBG studies in your workup. And it stands for meta-iodobenzyl-guanidine, and it's linked to a radioactive iodine. And it's basically an analog of noradrenaline, and it accumulates in the storage granules of adrenergic tissues. It can be seen in neuroendocrine tumors, but actually MIBG has only low uptake. Octreotide is actually better. MIBG is better for PHEOs, paragangliomas, and neuroblastomas. However, they still do this sometimes because if there is more MIBG uptake, it will guide therapy because you can then do an I-131 MIBG therapy instead of the lutetium DOTA-TATE. But that's not always routine, and that's not in all centers. An example is same patient. On this panel, we can see the Octreotide study. The patient has multiple liver metastases and bone metastases, okay? That's all these little foci. And then you can see the MIBG study. You can see the liver metastasis, but it doesn't really pick up the bone metastasis as well. So when we do this, the clinician will basically say this patient will probably benefit from the DOTA-TATE therapy rather than an I-131 MIBG therapy. And that's what they do to basically guide therapy. but again, it's only done in certain centers. More commonly, MIBG will be done for things such as pheochromocytoma tumors. So this is a tumor of the adrenal gland. Here it is on MRI, and there it is lighting up easily on MIBG. And paragangliomas to look for distant disease. This was the initial tumor in the left adrenal gland area, left upper abdomen, probably in the retroperitoneum. And then we can see that the patient also had bone metastasis scattered in the skeleton. It's great because you can do whole body images, which is much more convenient rather than CT scanning or MRIing the whole entire body. Okay, so let's switch gears to PET scans. And PET scans includes the DOTA-TATEs, the FDG, and the other tracers. I'm mainly going to focus on DOTA-TATE and FDG and how they are used nowadays for management. So PET imaging, specifically, it's using the positron emitting radiotracers, so F18, Gallium-68 are the main ones. And the gallium DOTA-TATE peptides, there are many of them. There's DOTA-TATE, DOTA-TOC, DOTA-NOC. We use DOTA-TATE here in Calgary. So PET imaging, just so you know, it's a PET scanner, and it's different from the nuclear medicine camera that you see in other nuclear medicine departments. There's PET scanners available in each province, but only in certain hospitals. So it's very limited in terms of availability. And the idea is what you have is the F18 or the Gallium-68 is a positron emitting element or isotope, and it basically positrons are positive charged beta particles, and it basically goes through an annihilation reaction, which is where it combines with an electron, and two 511 high photons basically are emitted at 180 degrees, and this camera system is able to pick up on that. And because of this very sophisticated camera, we're able to have a spatial resolution of basically 5 millimeters. Whereas the gamma camera, the spatial resolution is not as great, maybe 1 to 1.2 centimeters. So the PET scanner is by far has better spatial resolution than the gamma camera. In terms of the DOTA peptides, as I mentioned before, that there are 3 major peptides. They're all basically somatostatin analogs, but a little different from Octreotide. And we bind them to the Gallium-68, which is the positron emitter. Basically, the DOTA-TATE, DOTA-NOC, and DOTA-TOC all have a little bit different receptor variability attachments. So they attach different receptors a little differently. For the most part, we only use DOTA-TATE, but you will see that for the most part, they are comparable in terms of accuracy, sensitivity, and specificity. So very similar so far from the data, from the research. They have a half-life of 68 minutes, so very short compared to the 2.8 days that we saw with the indium. And we can use a generator that's on site in the hospital. What you need to know is that it is better dosimetry for the patient in terms of the radiation dose. The other thing is it's more convenient for the patient. So we just inject the patient, and then in an hour, we image the patient. The other thing is that the patient does not have to do any special preparation for this test. There is no come off your somatostatin medication or anything like that. You can just go ahead and continue as is. You don't have to even fast for our test. This is an example from an article showing one of the first Octreotide scans and DOTA-TATE and how they compared, and you can see that the DOTA-TATE has better spatial resolution. This is the same patient, but you can see lesions better on the DOTA-TATE. The spatial resolution could go down to 5 millimeters, whereas with the Octreotide, it's only 1 centimeter, maybe 1.2 centimeters. There's also less normal tissue background, so you can pick up metastatic lesions much better with the DOTA-TATE. So they have high sensitivity and specificity, and that's our ability to detect the tumor. Here's an example of a normal variant. This patient had a lesion in her thoracic spine. And when we do the DOTA-TATE, here's a MIP or a picture of the DOTA-TATE, and we can fuse our DOTA-TATE with a localizer CT, so we know where the uptake is. Here's an example of one of the first patients we did at Foothills Hospital, and we can see that the patient had multiple liver lesions, and we can see it quite easily. and where they are. Some of these lesions were cystic at its centrally from necrosis. Here's that lesion with the pancreas. We did an Octreotide study and the patient had Octreotide uptake. And we also did a DOTA-TATE study, and it shows just a comparison SPECT CT versus the DOTA-TATE. You have better spatial resolution and you're able to see more accurately where the tumor is going. And then just another example of how this is Octreotide on SPECT CT compared to the PET, and you can see that by far DOTA-TATE has better imaging resolution. Here's an example of a patient with bone metastasis. That's one thing so far we've noticed is that you're able to detect small lesions that weren't seen on CT or MRI. We have these small little lesions that are DOTA-TATE avid that you don't see any change on the CT scan because you'll see the changes on DOTA-TATE before you see changes on CT, and that goes with most bone metastasis. And the MRI, again, because MRI tends to just focus on a certain area, such as the liver or the abdomen pelvis, it won't catch the chest, and so we would miss the bone lesions. So DOTA-TATE gives you that whole body picture and is able to detect small lesions. And this is quite a small lesion, and we can easily see it on our DOTA-TATE. So it's good for bone metastasis. And we were able to see it when there is metastasis in the peritoneum. So this is a peritoneal metastasis. In this case, for example, it was so small, it was actually missed on the CT because it's small and it doesn't light up the way it does with DOTA-TATE. So you're just able to pick up the lesions better. Okay, switching gears now, let's talk about FDG PET CT because some patients will now have an FDG PET CT, and I guess the question is why. So as you know, FDG PET CT is really the first routine PET study that we've done for tumor, and it's most commonly used in things such as lung cancer, colon cancer, ovarian cancer, and all sorts of different cancers. But it's starting to be used with neuroendocrine tumor imaging, and I'll explain how it works. This is FDG. So we label FDG to a radioactive positron emitting fluorine 18. The FDG is basically a glucose analog. So it behaves just like sugar that we have in our bodies, except we removed the hydroxy group with F18. And it basically gets taken up by cells and it accumulates there so we can image. And we've noticed that things such as infections or tumors will have increased FDG uptake compared to normal tissues. So that's what we've noticed. Here's an example of the normal distribution of the FDG PET. And you can see there's a lot of brain and normal uptake in normal structures. There's some low-grade activity, but tumors really lights up. Here's an example of Octreotide. This patient had a lesion in the bowel as well as liver metastasis. This patient also had an MIBG study with low-grade MIBG uptake, not as clear as in the Octreotide study. But when they did an FDG, there's only low-grade uptake. And actually, that is what is expected. So you may ask yourself, well, why do an FDG PET CT study then? Well, the reason being is that in general, well-differentiated tumors do not take up FDG. So if you have a well-differentiated neuroendocrine tumor, you're not going to take up FDG that well. You're going to take up DOTA-TATE instead, and that has to do with the receptors. But they found that as the tumors dedifferentiate and become high grade, they start to become more FDG avid. That means that basically if you have FDG uptake, your tumor is probably dedifferentiating, and that is associated with a poorer prognosis for the patient. So that's actually important. The other thing is that if you're no longer taking up DOTA-TATE and you're dedifferentiating, but you're now starting to take up FDG, you probably will not benefit from a therapy such as lutetium DOTA-TATE because the radiotracer isn't going to go to that tumor. In which case then the clinician will use that information and can decide to consider other therapies such as chemotherapy. So that's the utility of FDG PET. So a lot of patients are now getting both studies, DOTA-TATE and FDG PET, and using that information to guide management. Here's an example of an Octreotide scan. So Octreotide is still useful. We can still see that there is intense uptake on these lesions in the bowel and mesentery, probably lymph nodes. The FDG is only low grade. It's not really striking. And this is another patient where we can see similar uptake. This is the FDG PET on the top panel, and the liver lesions are FDG avid, and the Octreotide lesions are not that avid, but they're still there. But it's starting to be more FDG avid. So again, that's given the clinician an idea of histologically what's going on with the grade of the tumor. A nice example of a pancreatic mass with DOTA-TATE, intense DOTA-TATE uptake with only very low-grade background FDG uptake. So this patient would be a candidate for lutetium DOTA-TATE therapy. So that's basically, this is a nice summary of the different nuclear medicine, again, indium-111 Octreotide versus the Gallium-68 DOTA-TATE. Again, for sure, Gallium-68 DOTA-TATE is, in my mind, a better test. It has, studies have shown, it has better spatial resolution. It's more convenient for the patient in that you do the same day imaging and less radiation dose to the patient, and it's very sensitive and it guides therapy. The Octreotide is excellent too, but it doesn't have as well spatial resolution, and the imaging can be over 2 days. And we can't detect lesions less than a centimeter very well. But again, it still guides therapy, and that lutetium, it still decides whether or not you would benefit from lutetium DOTA-TATE, for example. And then FDG PET is good for identifying the high-grade tumors, for prognosis of the patient. Is this patient's tumor dedifferentiating, and whether or not they would benefit from DOTA-TATE, lutetium DOTA-TATE versus chemotherapy. Now, there are other PET studies. I'm not going to talk about them too much, but there's the F18 DOPA imaging, which we start to do these tests when we can't find the tumor on any imaging modality, and that's like trying to find the primary tumor. You know that the patient has liver metastasis, for example, but you don't know where it's coming from. You can do this F18 DOPA test. It is offered in Edmonton. I'm not sure where else, but it can be done. Just one study showed that DOTA-TATE still is more sensitive than the F18 DOPA PET. And again, this F18 DOPA still is not able to assess for PRRT suitability. And then there's a C11 hydroxytryptophan study, which is probably only in the States because the C11 is a short-lived radioisotope. And again, it's when you need to troubleshoot when you can't find where that neuroendocrine tumor is. Okay, so then those are basically just an overview of all the different types of radiology and nuclear medicine. Just in general, they are complementary, and you really can't do one without the other. Ultrasound is good for characterizing lesions such as the liver lesions and guiding biopsy. CT is your bread and butter imaging modality that you need to know where the tumor is, where it's spreading to, and where it's metastasizing. MRI is excellent for liver, pancreas, and to troubleshoot certain lesions. And of course, Octreotide and the DOTA-TATE PET, also important and complementary to the radiology imaging, and it's able to identify disease in some cases better than CT and MRI in certain situations, and is good for assessing suitability for therapy. So that's basically my presentation, and I will be happy to answer any questions.
Thank you very much, Dr. Chan. That was an excellent presentation. I would now like to invite our participants to send any questions that they might have into the chat or the question box on your GoToWebinar little box that comes up. It should be on the right-hand side of your screen, and you can type your questions in the bottom sections. So while we wait for participants to send in some of their questions, we do have one already. So let me read through this for you. This patient has been having MRIs every 6 months for the last 12 years. They have a pancreatic neuroendocrine tumor, and they say that the MRIs are consistently inconsistent. They measure tumors bigger sometimes and smaller sometimes. They say that gallbladder is unremarkable, yet they have no gallbladder. So the question is, why are there such discrepancies? Is it, the individuals who are reviewing these scans, are they rushed, or what do you think could be contributing to that?
That's a good question. That's an excellent question. It's hard to know uh, without reviewing the individual images. Certainly, it helps to go to the same site. So that they have the previous
Okay.
to compare to. That would be helpful. If sometimes if you go to one site and have your MRI read at somewhere else, it could be a bit different. They may not have access to the priors, and so they may not measure it the same way. Certainly in Calgary, for example, there are multiple centers where you can have your MRI read by different people. And so in our group, we try to do it similarly. We save the measurements so that the person can see how we measured it, because you can imagine how some tumors you can measure it a little differently and make it look smaller or larger. And it's really important to see really what's that going on over several studies. So sometimes if you're having PACS issues or you're not available, it's not obvious where that study was done previously, and the radiologist may just not make the proper comparison or not measure it the way the other person did. And so that can actually add to differences. So I would say talk to your clinician and ask them. And clinicians can actually go to the radiologist and review the studies. And that's part of the radiologist's job, is to basically talk with the clinician because there is a story behind it. And the radiologist, if they made a mistake, they should know, and they should get that feedback, for example, if that's the case, or if they missed comparing it to another study that's actually very important, then they can actually go and make an addendum and make that improvement. But certainly, clinicians will start to have a group of radiologists or hospital site that they're more comfortable with, that they know that they can go and talk with. And so talk with your clinician in terms of where they recommend going. And that would be my advice. But yeah, that could be pretty frustrating, I would imagine.
Yeah, I mean, I have a personal experience with difference between the size of tumors measured on an ultrasound versus an MRI, which I think would make a little bit more sense. But MRI to MRI, I think I can understand the concern.
Yes, exactly. And if they, oh,
Okay,
yeah, go ahead.
go ahead. No, go ahead.
Oh, I was just going to say also, the other thing is MRI, if they took the measurement on a different image sequence, it can also affect things in terms of their measurements. So,
I see. Okay, that's good to know.
yes.
So when talking about MRIs, you mentioned to us the contrast that's used called gadolinium.
Mhm,
What about the contrast of Primavist? Is that
mhm.
commonly used for neuroendocrine tumors of the liver?
So Primavist is great for finding lesions such as FNH, so other lesions. So it can be helpful for basically making sure it's not a benign liver lesion, which can sometimes be an issue. So the the radiologist definitely has the ability to use that as well as gadolinium, and to pretty much put it all together and to figure out whether or not they think it's a neuroendocrine tumor or if it's another lesion. And so that's when they kind of use Primavist versus gadolinium. They probably will end up maybe even using both, or they may do the gadolinium, not be 100% sure based on what the information they have, and they might call the patient back and say, we're now going to give you Primavist. And it's basically, like you said, a way of troubleshooting, trying to figure out what that liver lesion is. So yes, so that is another
Okay,
um, contrast.
okay, great. And why are MRIs not used for lung imaging
Mm.
typically?
Yeah, it's not typically used for the lung because of the air, so it can be difficult. CT is excellent. It has great contrast between soft tissue, which is what tumors are, and the air. So it's excellent. Whereas it's not great with MRI. It might change in the next few years. MRI is changing and improving leaps and bounds. The technology is amazing. But at this point, MRI is really, it's better for even vascular structures. The other thing is that the heart moves, and sometimes MRI can take some time to acquire. And which is why
Hmm.
sometimes some patients are also claustrophobic. So you might have to gate the MRI, for example. So it just depends where it is. We have used it to troubleshoot things in the mediastinum, tumors in the mediastinum, but really CT scan is excellent for the lungs, and it's so widely available. So CT scan is pretty much your primary modality for the lungs.
Okay, thank you. And with respect to CT scans, why is it some patients are asked to drink a liquid before they have a scan, but others aren't? And this is, I'm assuming, not for lung CTs.
Yes, exactly. So that's the oral contrast, and that oral contrast is used to basically, I guess, fill up the bowel and basically help us evaluate the bowel. We found that it's not as useful as we thought. It's useful if the patient has not a lot of fat in their mesentery, and then all the bowel is kind of collapsed on itself, and you can't see if there's a lymph node or a tumor because everything's kind of collapse on itself. But most of us have a little bit of fat to separate out the bowel, so it's not usually an issue. But when you first have a CT and they don't know what the issue is and just maybe a generalized abdominal pain, they probably will give you a bit of what's called oral contrast to drink, to just so that we can see where the bowel is and separate that from other conditions, like other structures. But if you're doing CTs a lot, then eventually we don't need that as much, and so we might just skip it now.
Okay, great, thank you. So we have another very specific question from a participant. This individual had a 3 mm net at the terminal ileum, which was found on a colonoscopy, but it did not appear on a CT, an MRI, Octreotide, or a Gallium-68.
Mm.
Post-operatively, they found metastasis to the lymph nodes, which was not seen on the scans either. Are there other scans that this person should have done at this point? If so, which ones?
That's an excellent question. It's 3 mm is quite small, so I would have hoped that DOTA-TATE would have picked it up, but it doesn't sound like it did. They said sometimes that F18 DOPA might be able to find the tumor at this in the terminal ileum regions. It might be helpful. So maybe an F18 DOPA could be useful. The other thing is it just may be so small and that it's just below any imaging modality to pick it up. And at the end of the
Mhm.
day, it's the surgeon that actually has the best ability to pick up tumors. And I'll say some of our surgeons here in Foothills will go to neuroendocrine tumor rounds, and all the imaging modalities, DOTA-TATE, MRI, CT, we will not say we see any liver metastasis. And then the surgeon, Dr. Pasica, will say, I put my hand over the liver and I could feel the metastasis studding the liver, and I can feel the tumor when when I'm in the
Hmm.
operating room and I can feel the bowel. So at the end of the day, the surgeon is actually probably better at detecting a lot of the tumors than imaging. We try to do our best, but obviously still we will miss things. I would, you know, you know, maybe if things get larger, yeah, we would pick up the tumor, or it could just be
Mhm.
that it's not DOTA-TATE avid, because not all tumors will be DOTA-TATE avid. In which case, then another PET test, such as a DOPA, F18 DOPA, might be able to pick up the tumor.
Okay, thank you.
Yeah.
And I guess, a patient who's not had surgery, that creates an extra layer of challenge because there's nobody going inside to actually feel
Yes.
around for those tumors. So if you're relying solely on imaging, that could be a problem. And I guess that's why we have patients with like unknown primaries, for example.
Yeah, exactly. And so if it's not seen on DOTA-TATE and it's not seen on anything else, then you might consider the other rare PET things. I mean, really, it's only F18 DOPA that we have access to here in Canada, and that's a research study in Edmonton. But yeah, you have to start thinking about, should we go into other PET, or do we just serially follow up and see if we can see anything with time, like every 6 months, for example. So really important discussion between you and your clinician.
Okay, thank you. Next question is, are PET dotates useful in follow-up for lung neuroendocrine tumors? And if so, how often?
Mm, that's a great question. Um, in terms of follow-up, just in general, we don't have guidelines right now, and we talk about what should we do in terms of follow-up for any tumor, and we kind of just go by, I guess, really how the patient is feeling and how aggressive the tumor was behaving at the time. So then if it was a really aggressive tumor, we might say the shorter interval, like 3 months or so, 3 to 6 months. And if we, based on tissue characteristics and what it presented with, how big it was when it presented, we might go longer, maybe 1 year, 2 years. So just in general for follow-up, we're not sure in terms of the right follow-up, and hopefully this is something that we can look at in the future for research. But right now, I think everyone's kind of just figuring out based on that individual patient. In terms of the carcinoid neuroendocrine tumors, there are the typical and atypical carcinoids. The typical will probably have the DOTA-TATE activity. So it probably would be useful for following up. When we do just keep in mind when we do PET CT scans, we are using a localizer CT, so it's not as thin a cut as the CT scan. So the typical CT scan that you do for CT chest, you have thinner cuts. You can go down to 0.6 millimeters, which is really thin. So you will actually have better resolution. Whereas if you're just doing DOTA-TATE, you might not have that resolution, and you will have breathing motion artifact with our localizer CT. So just keep that in mind. We see most nodules on our DOTA-TATE PET or PETs in general, but the CT chest is excellent. It has better spatial resolution. So just keep that in mind. So again, you probably would want to do a CT chest and not just 100% follow with a DOTA-TATE.
Okay, that's very interesting. Thank you. And so for individuals who have nodules on their lungs, and I've been told that a lot of us have nodules. Is that something that we should be worried about? Should there be different scans used if a nodule is picked up on the CT? Like how should we handle that?
Yeah. So again, keep in mind that when you have small nodules, like little tiny nodules less than a centimeter, like 2, maybe even 5 millimeters, they really are better assessed with follow-up CT chests. And then they have, based on the size, they have specific recommendations in terms of follow-up for the clinician, say 3 months or 6 months or 1 year. The thing is that your PET scan, because of that, you don't have as good resolution and there's breathing motion artifact, especially in the lower lungs. You might not be able to accurately say whether or not there's true FDG or DOTA-TATE uptake. So you have to be careful there. And I think most people would say CT scans for sure are the best imaging modality. But if it's large enough, you could do the DOTA-TATE PET or the FDG PET to follow up. But most people would say, you know what, let's just do a CT chest. It's easier to get and it's more widely available. So you might want to just follow it up with a CT chest.
Okay. Next question is, when a primary carcinoid lung metastasis has metastasized to the bone, would you recommend both an MRI and a CT?
Okay, so if it's metastasized to the bone, so interestingly, if it's a neuroendocrine tumor, bone metastasis is actually, they found it's better picked up on an Octreotide or DOTA-TATE than plain CT. MRI, I'd have to double check, but MRI is excellent for bone. The thing is that you have the added ability to be more specific with the DOTA-TATE, because if there's DOTA-TATE uptake, you can be pretty confident it's probably metastasis, keeping in mind some bone lesions will also have, that are not metastasis, will have DOTA-TATE uptake, but then again, they will correlate everything. So you could go with MRI or DOTA-TATE PET or even Octreotide PET as follow-up. Again, it depends on the size of the lesion, but those are probably more accurate than CT. CT, when you have a metastatic bone lesion, it takes some time for the metastatic bone lesion to actually destroy bone so that we can actually see it on CT or change it on the CT. Whereas you can detect things earlier with Octreotide or with MRI because they are able to pick up the receptors, or they will show the soft tissue itself before it actually starts to really destroy bone. So that's why CT picks up changes later than the other two modalities. So really, I guess it just depends on where you are. Maybe an MRI or an Octreotide / DOTA-TATE would be useful.
Okay. So hopefully that response also addresses the question from an individual, which is what is the best scanning method for bone metastases if a gallium-68 is not available?
Yeah.
Um,
In general, for neuroendocrine tumor,
yep.
bone metastasis, I would suggest actually an Octreotide study would be better than a bone scan. Now, if you do CT, you can follow the lesions on CT if you're following other lesions, say in the liver or whatnot. But I think studies have shown that bone metastasis is picked up faster in Octreotide than in other modalities. So you would consider Octreotide first as a general statement.
Okay, great. So we have a number of questions left and not too much time. So let me just scroll here. Next one is this individual has viewed several CT reports. It appears that there is not a standard for tumor definition. Why? I'm not sure I understand what they mean by a standard tumor definition. Does that sound like
I'm
something you're familiar with?
No, I'm not actually sure what standard tumor definition. I'm not sure actually. I'm sorry, I'm not sure
Okay,
what
so
that means.
why don't the person who wrote that, if you want to clarify your question, if you can, that would be great, and we'll see if we can get to it. I'm going to move on to the next one. This individual says, after having a gallium-68 scan, there is an avid neuroendocrine tumor confirmed in the pancreas. It seems to show at 1.3 centimeters. It's smaller on the PET scan than it was indicated on the MRI at 1.8 centimeters. The MRI also shows another one without indicating the size that the PET scan says might be too small. So let me just get to the question here. The difference between the sizes could mean the difference between needing surgery right away or not. My surgeon wants to wait and do another MRI in June. What would you recommend for someone in this scenario? So there's two different imaging and two different sizes, and the difference could make an impact on whether or not they have surgery.
Mhm. Um, Personally, so in terms of the pancreas, I would say that probably the MRI is something that you can rely on because you have excellent spatial resolution and tissue resolution in terms of contrast resolution. So I would say the MRI in this case I would favor. Keep in mind that in DOTA-TATE PET studies, we found that the pancreas sometimes has normal islands of pancreatic cells that take up DOTA-TATE, but turn out to not be tumor. And so in those, the research so far has said that with those pancreatic DOTA-TATE avid lesions to defer to the MRI. So the MRI is still, I think people are still weighing more on the MRI of the pancreas than they are on the DOTA-TATE read. So I would probably go with the MRI. It's hard to know in every situation, so I
Sure.
will say that. But in general, the MRI people are just more. They have an idea on how it affects management. They have more experience with the MRI. DOTA-TATE is something that's coming out right now that we're still not 100% sure how it fits in terms of the algorithm, but certainly MRI, we do have an algorithm in terms of what to do next, and people are more comfortable with that.
Mhm.
So that's what I would say. Having said that, we have done where a patient has something producing insulin, probably coming from the pancreas, and the MRI didn't show a lesion, and then basically they go on the DOTA-TATE and go from there. So there are individual patients situations that are different. So I would be
Mhm.
careful with what I say, but the MRI is excellent at the pancreas. So I would just at this point, I would favor the MRI. The zero 0.5, that is different. And I would maybe, talk with um, the radiologist and just say like, go back to the person who read the MRI and say, well, this is the DOTA-TATE. Is there really a difference? Is this the same thing that you're seeing? And have them really correlate that, those two
Mhm.
imaging.
That's great advice. Thank you.
Yeah.
So next question is, when a person has experienced a severe allergic reaction to CT contrast dye, are there other dye options so that they can be able to continue to have the CTs?
My answer would be no, not with CT.
Okay.
Just because if you had a real severe allergic reaction, I think people would be too concerned to take that risk again. And I'm talking when you have severe, we're talking about anaphylaxis, where the airways shut down and you get all swollen and red. And it's pretty scary if you have a severe allergic reaction. So if it's a mild reaction, sometimes we pre-treat the patient with Benadryl or steroids, for example. But if it's severe, I would say no. Which case then because of a non-contrast CT is not very useful, then you might have to consider MRI as well as Octreotide or a DOTA-TATE PET to help bring the whole picture together if you can't have contrast on that CT.
Okay, great. Thank you. So we're at 7 p.m. We have one more question. So if it's okay with you, we'll ask
Sure,
you this final question.
sure.
So we're hearing a lot from our friends in the United States about the copper scan. What can you tell us about that scan, and do you think there's any chance we'll be having it in Canada anytime soon?
Oh, yeah. In terms of the copper scan, no, I don't think so at this point. I'll be honest, with Canada, we have a lot of regulations in terms of Health Canada. Dotatate was research based to get it, but now we have NetSpot, which is commercially available. But even that was hard and a hurdle.
Mhm.
And big thing is costs. Canada is more careful about costs, so usually we see Europe and United States being more progressive in terms of the PET imaging tracers, and it takes a long time for it to come to Canada. So I would say we probably, unless the research becomes overwhelmingly, yes, you have to do this. I would say probably in 5 years it would come to Canada. Again, it would be a slow
Yeah.
kind of research and then maybe to
Mhm.
routine clinical use. But we would probably have to wait a while before we get our hands on it. Some radio tracers end up not being used in the routine clinical use, and they just die and not get seen again because it's too expensive, or it's there wasn't enough research onto it. So I would probably at this point wait a bit and see where it is in terms of Canada, and just see. I mean, we're just Dotatate is only starting to really come into different centers in Canada, so I'd like to see where that goes with the Dotatate.
Okay, but are you hearing anything on the copper scans in terms of their quality, and are they better than gallium-68? Do you have any sense
No,
that you could comment on at this stage?
no, I don't. Most people are quite
Okay,
happy with the Dotatate, so I don't really, I'm not familiar with the advantages over Dotatate at this point.
okay, okay, great. So with that, we will wrap it up. Thank you so very much for your time this evening. This was an excellent session, and I'm sure widely appreciated. And for the folks out there, just to let you know that this will be available on the CNET's website, a recorded version of it, and we will communicate with you via social media and email once it's available and up on our site. But Dr. Chan, thank you again. It's been an excellent evening, and we really appreciate your time.
Thank you very much for having me.
Okay, have a lovely evening, everyone.
Great, thank you,
Take
bye.
care. Goodbye. Okay.